Hi everyone, we'd like to welcome you all to part 3 of this 3-part webinar series on Navident 2.0 TaP, Trace and Place Technology. So it's a paradigm shift in dental surgical navigation, and tonight we'll be speaking about TaP in the mandible. So part 1 was an overview of TaP, or Trace and Place, what we call trace registration. Part 2 discussed the use of TaP in the maxilla with a patient wearing a head tracker tag. And today's webinar, as I mentioned, will focus on TaP in the mandible. So the most significant difference between the maxilla and the mandible is that TaP in the mandible, we attach a tracker, jaw tracker to the patient's actual teeth, implant abutment, or fixation screw. So leading us through tonight's webinar will be 2 clinicians that viewers of these webinars will be familiar with, and users of Navident will be familiar with, conference goers, and people who've talked to our clinical and technical support team. Dr. Ido Bermanis is our Director of Clinical Operations here at ClariNav, and Dr. George Mandelaris, Navident Master Clinical Trainer, Lecturer, Author, and Periodontist from Chicago, Illinois. So Dr. Bermanis has a broad perspective in the dental industry, gained from over 13 years as a practicing dentist, obtaining a master's degree in biomedical sciences. His research thesis focused on the development of an innovative CT-based 3D biomechanical model of the human mandible designed for biomechanical orthodontic research. So we'll start with Dr. Bermanis giving us an overview of TaP in the mandible from a very nice video that he's put together that, along with this webinar, will be available on our website shortly after. Dr. Bermanis?
Hi, everyone. So that's our third and last webinar. As Jason mentioned, we're going to show the workflow for the mandible, and with the jaw tracker that actually can be used also on the maxilla. So let's start.
Welcome to our third and last webinar in the Navident 2 TaP trilogy. Today's webinar will deal with trace registration, or trace and place, in the mandible. On our first webinar, we have introduced Navident's new trace registration method, which utilizes natural structures already present in the conventional diagnostic CBCT scan, such as teeth, crowns, and abutments, and uses them as a natural fiducial for the registration, instead of the traditionally used artificial fiducial. On the second webinar, we went through the different steps of the trace registration workflow for a maxillary case, starting with the importation of the diagnostic CBCT scan into Navident, followed by the selection and marking of the structures for tracing, over to the installation of the head tracker used for tracking of the patient's maxilla, and the tracing itself on the patient's maxillary teeth. The navigated osteotomy step remains unchanged. On today's webinar, I'll review the workflow for the mandible, which oddly enough resembles the maxillary one, and therefore I'll focus mainly on step 3, because instead of the head tracker used for the maxilla, for the mandible we use another tag called jaw tracker. So let's go through the sequence. The CBCT scan is imported. This time I select the mandible. Note that even if only one jaw is present in the scan, I still have to place the red line at the level of the occlusal plane. I then indicate it is the mandible I'm going to be working on. Drawing of the jaw centerline curve, going through the scan, making sure no motion artifacts are present, marking of the inferior alveolar nerve canal, and planning of crowns and the implants. As always, the plan is being continuously and automatically saved. Next, I select the landmarks for tracing. In this case, these are teeth crowns, but artificial crowns and abutments can also be used for that purpose. Now that the planning part is complete, I can proceed to the installation of the jaw tracker. The jaw tracker assembly is a single-use part, which consists of a marker plastic tag connected to a bendable stainless steel wire. The jaw tracker is installed on the patient's jaw, by affixing its connecting bendable wire with a dual-cure composite resin to a tooth, crown, or abutment. Since no etching or bonding agent is being used, the removal at the end of the procedure is quick and simple. First, the wire needs to be bent into the right shape to position the tracker so it will face the camera and will minimally interfere with the motions of the surgeon and the assistant. We also want to minimize potential camera's line of sight interruptions. Using the bird beak pliers, the last 5 to 6 millimeters of the wire are bent for the attachment to the tooth on its lingual side. By default, the tracker should be placed at the front, with a clearance of at least 1 inch above the patient's chest to avoid bumping into it. I can now connect the wire to the tooth or teeth. I start with applying a thin continuous layer of material onto the lingual and incisal surfaces of the selected anchoring incisor. It can be convenient to use 2 teeth crowns and to place the wire just over the embrasure area. I now place the bent 6 mm part of the wire in the composite material, so it comes in contact with the lingual side of the teeth, while aligned in parallel with the tooth length axis, with the rest of the wire crossing over the incisal edge, or the embrasure in this case. I light cure for about 20 seconds, while holding the wire steady in its place. I add an extra layer of composite resin onto the lingual to completely cover the part of the wire that's in contact with the tooth, and I light cure it again. Lastly, I also add some material onto the buccal aspect of the tooth to create a larger, sturdy bulk. The whole process of adjusting and connecting of the jaw tracker to the jaw takes about 5 minutes overall. After the jaw tracker has been installed, I can move over to tracing. This time I will not go over the minor details since these have been reviewed on our previous webinar dealing with the maxilla. Tracing step starts with the calibration of the tracer tooltip, followed by the tracing on the teeth I have marked. Holding the tracer still, on the buccal aspect of the first tooth I selected, as close as possible to the location of my first landmark. And I trace by sliding the ball tip over the surface of the tooth, on at least 3 sides of it, buccal, occlusal, and lingual. As I trace, the points are being collected. "100 points have been recorded for this tooth, so I move over to the next landmark. I have to start tracing on the landmark, but I don't need to stay on the same tooth. I can continue the tracing on the adjacent ones as long as I keep my tracer on the surface. Accurate registration requires a minimum of 3 landmarks, but here I've marked 4, so I need to trace them all. I keep the ball tip on the surface all the time, making sure to perform frequent crossings over the incisal edges, tracing them too. We can see that an average single tracing takes about 17 seconds, so the whole tracing required for the registration of the patient's jaw with its scan would take about 1 minute. I now verify the registration's accuracy by touching with the tracer's tip on different locations on the teeth and comparing its physical location on the tooth with its virtual representation on the screen. Once accuracy has been verified, we can proceed to the surgical navigation part.
Okay, thank you. And I do hope that you were able to hear most of the video, if not all of it. So I take it back to you, Jason.
Thanks, Tito. I appreciate it. It was a really, really great video. And along with our maxilla video, those are both going to be available on our website, on the main page of our website, as well as the first webinar. So both those videos will be very, very complimentary to your learning. I see we have people online right now who are beta testers and master clinical trainers, and other people who have the software and the system but limited experience with it. So these two webinar videos and these 3 webinars all together will be a really nice resource for you. And now to share some of his experiences with mandibular using of the TaP, I would like to introduce George Mandelaris. George attended the University of Michigan from undergraduate through dental school in 1989. He completed a 3-year graduate residency program in periodontology at the University of Louisville School of Dentistry, where he obtained also a master's in science degree in oral biology. George, please share your cases and impression of TaP in the mandible with us. And thank you.
Yeah, thank you. Can you hear me okay?
Yes.
Okay, can you see me? Is my oh, here it is. Okay, there we go. Okay, great. All right, well, glad to be with everyone. I just finished a long day of work, so I apologize if I'm a little tired, but look forward to kind of sharing with you some of my experiences with TaP and the mandibular arch. So this is obviously a part of a much bigger presentation. Today we're going to be focusing in the mandibular arch and trace in place and review a few cases. I wanted to share with you, just some of the history of guided surgery and some of the elements that I consider to be very successful or very key in being successful for totally guided implant surgery, which navigation can, is kind of the next step. This is a paper that Alan and I published several years ago along with Samantha King and Mark Nevins, and we were basically looking at what are the things that a clinician really needs to kind of be careful and mindful of in order to have predictable results when the osteotomy site and the implants are being placed using a stereolithographic surgical guide. And so we highlighted the quality of the CT imaging, the reliability of 3D reconstruction. Sometimes it's very difficult to make out crestal bone if there's radiographic artifact and so forth. It's difficult to kind of make out precisely where some of the bone peaks are. The quality of the rapid prototype medical modeling, the accuracy in determining, as I mentioned earlier, the crestal bone position, that influences the vertical position of implant placement when you're planning this, and now you're not just creating an osteotomy site, but you're also placing an implant based on these characteristics. Dimensional stability of a stone model. Today we're going to use intraoral scans, which I'm going to show you some cases and how I work this up today. This is still a prosthetically directed endeavor, and we can't forget that, even though the technology is advancing. Accurate stability of the scanning appliance, that obviously doesn't necessarily pertain to what we're doing. Radiographic artifact, movement and fit of the guide during surgical execution, knowledge and experience of the clinician, and it's the old adage, no matter how amazing the technology moves us forward, it's still garbage in, garbage out. So with dynamic navigation, really all these key elements are relatively, the same things still apply with the exception of a few. Today we're using intraoral scans. Obviously we're not necessarily getting stone models anymore, but most importantly, it's all about the planning. So whatever you plan is what you can expect. As I mentioned in the last 2 sessions, the team that they've assembled at Navident is really spectacular, and they're really there to help you be successful, me included. So anytime there's been problems with my cases, and there's certainly been some, they're always there to help and make sure that I'm successful. And what I've found is that most of the time I'm the problem, and you just have to reach out to get the solution. As I mentioned before, technology is not a substitute for making good decisions. We still need to understand the scans and ask the question, is the marrow quality going to make me, is it favorable, and do I have vascular potential for successful osseointegration? It must not usurp biologic and surgical principles. So today we're going to focus on the mandible, and we're also going to focus a little bit on planning. So as I mentioned earlier, in terms of trace registration, the registration is accomplished using a recent CBCT and plan with software. Today we're going to be tracing 4 reference points. Before we were doing 3, now we're going to be doing 4. And if you can get a quadrangular plane, that's great. After the registration process has occurred, we always want to do an accuracy check with the tracing pen and also ball, today it's a ball, and also with our drill tips. Once you've got confirmation and that you've got accuracy with the trace registration, we'll calibrate the axis of our drill and the handpiece alone, and then move to registering the drill tip, and then another accuracy check to make sure that that is correct. Once the accuracy check is confirmed, osteotomy site preparation can begin with dynamic navigation. So just kind of a review with what Ido showed you. Today we're using the head tracker, the maxi rep, and then the lower jaw tag, as you see here, the jaw tracker, the tracer, and then the W&H handpiece, which attaches very nicely to the, as you see here. We need to make sure that that thumb drive is, that thumb screw is tightly adapted. And then this is the new tracer that's being used today. It's a ball tip, so you'll notice a little difference in the registration software as well. It's moved from an arrow, which I'm going to show you, to one that's more of a circle to represent the ball tracer that you have here. So let's just look at Joel. Joel is a patient in the practice for quite some time. We placed implants in a kind of a historic fashion at numbers 30 and 31. He's recently lost tooth numbers 29 and number 18. So this will be single tooth implant placement in the posterior right and left mandible. And the first thing we're going to do is basically secure a set of stone models and do a diagnostic wax up. In today's digital world, basically we'll do an intraoral surface scan using the Trio surface scanner. I'll send that to the laboratory, and they'll do a digital diagnostic wax up, which they'll send me back as an STL file. And now I'm going to import that into the CT scan using the software, so that when we plan the implant surgery, we're planning with the prosthetic mantra, we're planning with the prosthetic heart, the optimal final tooth position. So the first thing that we're going to do is we're going to kind of remove a lot of the excess anatomy that we don't need to plan, which is going to be, as you see here, a number of the maxillary teeth. I'm then going to go ahead and basically select several points, 3 in particular to match the STL files, and then I'll select a few more to get that even more fine-tuned. So we go ahead and add our landmarks in the CT scan, add our corresponding same landmark in the STL file, and then go ahead and register the application. Once that's registered, I can then basically change the planes. So I can fine-tune that registration even more in the X, Y, and Z axis, or the yaw, pitch, and roll, which you see here under manual adjustments on the screen to my left. You'll notice that they're all pretty much in the same vertical column. And they're not exactly accurate. So if you look at the lower central incisor, you'll notice that the STL file is a little bit lingual compared to the position of the tooth. So I'm going to just change the yaw, pitch, and roll, and you can see the manual adjustments now on the right that all have been modified just a little bit, making the registration of the lower central incisor and the molars a little bit more correct. The file that I like to use a lot is on the upper right, so you can see that that really kind of fits nicely the axial slices. And you see we have a pretty nice registration here. From there, I'm going to go ahead and I'm going to trace out using the virtual tooth. I'm going to map out the mesial distal, buccolingual, and most importantly, the vertical dimension of that digital diagnostic wax up. That's what the prosthodontist or restorative dentist is telling me. That's the position that they want the teeth in. That's what I'm going to plan from. So I basically map out that tooth using a virtual tooth, and then I'm going to go ahead and plan and place the dental implant as you see here. In this case, it's an Astra 4.2 by 9 millimeter EV, and the same at number 19, but we're going to use a 4.6 by 10.5 implant there. So again, very accurate and precise prosthetically directed implant planning in the digital world using the most sophisticated technology with navigation. So again, the jaw tracker, it's really very simple. I know we have Luigi on the call tonight. I'm very grateful to have met him. He's really kind of helped me out quite a bit in my career in getting me to the next level. And we spent a lot of time in his office making these stents. Today those are no longer really applicable. We use this jaw tracker, and it's very simple to just attach it with the dual clear composite, as Ido was saying. Even a periodontist can do this. So you see me in action there, and lo and behold, it actually sticks. It doesn't move. It's pretty simple, and it's relatively rigid. So I've applied some iodine on this patient to minimize any bacterial contamination that I might take from the face and bring it into the mouth. There's the jaw tag in place. And now I'm going ahead and using the tracer tool. I've selected my 4 reference points, and now I'm going to go ahead and trace those out. So we use the jaw tracker here, the jaw tag, as you see there on the left-hand side. The calibrator that we were using earlier has kind of been updated to this model here. So I'm going ahead and registering that. I'm tracing, as you can see, which is essentially a contact map. We're contact mapping 4 points and 100 points per tooth. So there I am in action, kind of tracing the teeth and irrigating the area and using a traditional guide. But I still like to do this from time to time. I still like to have a belt and suspenders approach, so I've kind of placed the implant using the most sophisticated technology, and I've placed an Osteotomy smart peg to show the trajectory of the implant coming through. I'm a little bit to the lingual, but nonetheless still very much in a prosthetic position that should be quite favorable. And when we're done with the surgery, it's very simple to just remove the jaw tracker. It comes off very, very nicely, very clean. So the clinical workflow as I see it and how I use it in my practice is the first thing that I do is position that jaw tracker, confirm its stability and comfort for the patient. I'll orient myself and my staff. I try not to touch it when possible, and everybody kind of knows where it's at. I'm going to go ahead and select 4 distinct points in the dental arch and indicate them as a starting reference for tracing on the software. We register the tracer tip to the software, as I showed you with that device earlier, and I'll show it to you again. We'll trace the teeth at the beginning at each designated point, previously marked and registered. Again, this is more or less like contact mapping of the teeth. And then once we're done, we will do an accuracy check to make sure that that tracing was correct. If it's not correct, we're going to retrace. If it is correct, we'll kind of move on. We then register the handpiece. Once that's registered, we'll register the drill tip and another accuracy check. Again, you're checking the tip of the drill. That's what is being measured. If it's not correct, we're going to re-register the drill tip. If it's still incorrect, then we're just going to scratch everything and go back to number 1 and start the process over again. Again, garbage in, garbage out. All the accuracy builds on your history. So if you're not accurate at step 4 or 5, your problems are only going to compound as you go forward. So take the time and make sure that everything is correct from an accuracy standpoint before you start the osteotomy site preparation. At that point, we'll begin our osteotomy site preparation. We'll switch the drills, insert a new drill into the handpiece, and register that drill tip, another accuracy check, enlarge the osteotomy site until it's complete. At that time, we'll go ahead and mount the implant and almost, pretend that the implant is a drill tip. Once it's affixed, we'll register it at the apex, do an accuracy check, and then make sure that the implant is placed using navigation. Although that may not be so critical as I'll show you in a study that we just had accepted to JOMI. We'll consider the evalu nav by a second CBCT scan, and then positional accuracy compared to the plan. So here's a case where we elected not to do any vertical ridge augmentation. There's some proximity to the inferior alveolar nerve. Basically, we had an implant placed at the number 28 position, and so we're going to 27 position rather. So we're going to go ahead and place 2 short implants and tie these 3 fixtures together for a fixed prosthesis. So there's my planning. This is a 4x3 times 6 millimeter Astra implant here. And here I am doing my trace registration, placing the jaw tracker into position with the dual cure composite, tracing out the teeth, and there's the patient, as you'll notice. I positioned the jaw tracker to the left a little bit, and one of the things I want to mention is that with a stereolithographic model, and with other techniques, I wouldn't, with the stents, I wouldn't have had the opportunity to use the bite registration. So, making this somewhat comfortable for the patient, relaxing the muscles of mastication with a bite registration, there, a bite block to kind of keep them comfortable as we go through the surgery. So again, the jaw tracker trace registration, as we've highlighted earlier, I'm indicating the tips, the positions that we're going to trace, and we're going to do some contact registration. Now, holding the tip until it registers, and then tracing that tooth, and then moving on to the others. At the end of that trace registration, an accuracy check. Now this is a little different today because we're using a ball tip instead of a little metal tip as you are indicating here. With that, it's basically an arrow as we discussed earlier, but today with the ball tracer, you're going to look at something that doesn't have an arrow. You'll see actually a little ball that represents more of what you're using to do your contact mapping. Again, the calibrator is a little different. Today we're using that white jig that I showed you earlier to calibrate the axis and do our tip registrations. But here you can see the tip being registered on this lower right lateral incisor, and there's my plan. So an accuracy check now is being done with the drill, and you'll notice that I'm not in the pulp of the tooth. I'm exactly where it looks clinically, so I'm confident that this accuracy is correct, and I'll move on now and do my osteotomy site preparation. This is the viewing screen that you see when you do your osteotomy site preparation, and then the target view, which is basically what you're looking at. This is kind of, what you're more or less engaging on to make sure that the entry point and the access deviations are correct. So real-time verification and validation of positional accuracy, which is really something that we've been needing for a long time in implantology, and something that we have at our hand today, thanks to Duran and everybody at Navident. So again, kind of interesting getting used to this, because here I am looking at a computer screen, really not looking at the patient. My assistant Gabby is kind of checking the patient, making sure there's no bleeding. She's making sure that the osteotomy site is looking good. She's got her eyes on the patient and the oral cavity, but my focus is really on the computer after all the accuracy checks and making sure that that is correct. Same thing there. Now, most of the time I like to think that I'm pretty good, but this technology really tends to humble you. You'll notice here that I'm almost 2 millimeters off of the entry point, while my angle deviation is around 6 degrees, and I'm 2.5 millimeters from the apex of that osteotomy site preparation. So I better change things. And it's nice to know that I need to change things now while I still have a chance to do that and before the implants are in place. So again, for me, real-time verification and validation of positional accuracy is the future. This is where we're all going. And I love having on-the-spot transparency. So those corrections are made, the osteotomy sites are finished, and then our implants are placed in this manner as you see here, and sutures. Our final x-rays verifying the positional accuracy, and you can see the position of the inferior nerve relative to these implants, which needed to be shorter in length. So this is what we're using now to not only calibrate the drill axis, but also register the tips and register the ball point. Here's a case here that we just did today. Tooth number 30, socket bone grafting was recently performed, CBCT imaging, and then we're registering the STL file and the Trios 3-shape scan. The lab has done a digital diagnostic wax-up. For me, that wax-up has been signed off by the restorative dentist or prosthodontist, and now I'm going to basically map that tooth out. That's important for me. More importantly, not so much like mesial, distal, buccal, lingual, but more importantly vertically, because I want to make sure that the implant is at the right vertical position to give the prosthodontist enough running room, enough emergence profile to really make this tooth look like a tooth. We need to, and that's one of the shortcomings I think with surgery, that sometimes we tend to plan and place the implants a little too shallow, and we don't give the prosthodontist and the restorative dentist enough running room to really create ideal emergence profiles. So again, based on that digital diagnostic wax-up, I'm going to kind of map out the virtual tooth, plan the implant, and once that's been planned and all the accuracy checks have been okayed, we'll move forward. So again, you can kind of see that this is the position of the implants, and here's our planning with a prosthetically directed mantra, not just kind of sticking implants wherever they need to go, but this is done consciously with the reference of a tooth, thinking about the restorative dentist first and foremost and making sure that they are successful. So with that, I wanted to show you a video. I was given a couple of videos, one from Luigi and one from my friend Sylvia De La Rosa from Seattle, who I had the good fortune to help know as she was a student at the University of Illinois. She's also a beta tester, so I'm showing you her video, and basically what you can see Sylvia doing here is here she's calibrating the tip. This is the tracer tool tip that she's calibrating. She's using the older calibrator, but nonetheless you get the point. So she's calibrating that, and then here are a couple of points that she has indicated that she wants to trace. So now once that's been registered, she's going to go ahead and use those 3 teeth to trace. And you can see where it'll say hold the tip here. So that's our first indicator. So there she is holding it. It's registered it now. The micron tracker has picked it up, and now she's doing contact mapping. She's basically got 6 points so far. She's going to hold that again, make sure that it registers. Once it registers, she'll finish the contact mapping. There she is holding it to the tooth. Once it registers, and now she's basically mapping out 100 points on the tooth so that it's registered. Once that's complete, she'll then go ahead and move to tooth number 2, and then she'll move to tooth number 3. You'll kind of hear almost like a video game kind of sound, like you're at the next level, and it'll take you back to the next phase, the next stage, to then do an accuracy check and move to calibrating your drill tip. So here's Sylvia basically doing the second tooth. You can see that, again, contact mapping. She's moving the tooth around. And it doesn't just have to be that tooth. It can be adjacent teeth as well, directly adjacent to that tooth. Basically, you want to get 100 points that have been mapped by contact. So here's the third and final tooth. Again, today we try to do 4 landmarks rather than 3. The wonderful thing about these guys is that they're always making innovation. They're always changing. So if there's a better way to do it next week, we might be mapping 5 teeth if it's going to make a difference. So there's always innovation going on with Daron and everybody in Toronto. So that's awesome. So here we are. We finished the trace registration, and now Sylvia is going to go ahead and kind of make sure that that is correct. She's calibrating her axis, her drill axis. And the important thing to do with this, unfortunately, I know this the hard way. I've made the mistake. Is you don't want to cover the jaw tag. If the jaw tag can't be seen, then there's an error already. There's a problem. So make sure your staff knows where their hands are, because the natural tendency is for them to kind of hover over the patient on the right side, like her assistant is doing, and cover that jaw tag. So here she's registered the drill tip. That seems to be accurate, and now we're going ahead and trying to get the entry point. I will tell you that there is no better marksman, there is no better sniper in the world than Luigi Stefanelli. He is 100% the best. This is not as simple as it seems, although he makes it look that way. So again, the accuracy check, and then we're going to move back and start our osteotomy site. So what I like to do is try to get the entry point as perfect as I can. I just try to get the tip so it's right there, right there in the bullseye. And then from there, I'm going to kind of go ahead and work and try to get my angle deviation as ideal as possible. So here we are from an entry point deviation. She's right on the money, and now she's just changing the entry point, or the angle deviation, so she's around 3 degrees, 2.5 degrees, 1 degree now, and she's placing an 11 millimeter implant, of which she has another 10.7 millimeters to go. So from here, it's just osteotomy site preparation, high irrigation, pumping the drill, and just watching what you're doing and being mindful and trying to make sure that we deliver the osteotomy site at the right entry point. We stay on target, entry point deviation, angle deviation, I should say, with our plan. So I'm going to move this forward a little bit because you don't need to see, osteotomy site preparation. You guys are all master trainers or experts in your own right. So I'll just kind of move this forward. But again, at each step, when she's changing the drill tip, it's another accuracy check to make sure that we move forward. So once that accuracy check with the 3 millimeter drill has been accomplished, now we start the osteotomy site preparation. You can see she's doing a great job. She's right spot on. This is Stefanelli-like accuracy, 0.2 millimeters of entry point deviation, and the angle discrepancy is almost 2 degrees. So it's it's spot on. Another almost 3 millimeters to go to finish the osteotomy site preparation, and she's doing a fantastic job. At that point, she'll step it up to the next drill, and as you see here, there she'll do another accuracy check to make sure that that's correct, and then finish the osteotomy site preparation. And this just continues until the osteotomy site preparation is done. And the nice thing about this too is that as you finish the osteotomy site, you see how things turn from green to yellow as you're getting a little closer, and then it'll start to be red here when you've exceeded your planned depth. So she's being very careful to not do that as the inferior alveolar nerve is not far away. Again, another accuracy check before the next drill is used, and you guys get the picture at this point. So accuracy check, osteotomy site, accuracy check, osteotomy site, accuracy check, osteotomy site, accuracy check, implant placement. And that's basically the theme. So from here, what I'll do is I'll kind of go into the next step, and I wanted to present this paper to you. We just got good news today that it was accepted in the Journal of Oral Maxillofacial Implants with some revisions. So we have to do some revisions, but for the most part, the editor has us accepted. And this is largely, I'm very lucky to be on this paper, but it's largely the work of Luigi Stefanilli. I'm really kind of riding on his back with this. He did an amazing job, and this is using some of the older technology, but you can kind of see the outcomes that we're getting. He looked at 231 implants in his practice, 89 arches, 125 implants that were fully edentulous. 125 implants, 28 of which were fully edentulous, 28 arches fully edentulous. And his deviations were, almost nothing. And what you see with guided surgery in terms of stereolithography is the entry points and the angle deviations are about the same. They're hovering right around a millimeter or so, but the standard deviations are huge. And what Luigi showed is that his standard deviations really were very, very minimal. What's also interesting is this is really the first paper to kind of show that how much he improved between the first 50 cases and the last 50 cases. Really improved by almost a half a millimeter and nearly 1.5 degrees of improvement. This is the abstract that'll come out, and basically again his numbers are mean entry point deviation of 0.71 millimeters from the plan, angle discrepancy of 2 degrees. You don't need to be, a Michelangelo of prosthodontics to have an amazing, prosthetic outcome when you have numbers like this. So as a surgeon, that's what I'm trying to hit all the time for my restorative dentist, to be the very best I can be to get the implants in the ideal and the most accurate position possible so that they can work their magic in the restorative end. I wanted to share this with you because this is probably one of the most interesting aspects, is that, the question is really, once you've done the osteotomy site preparation, do you then need to use the implant, as a drill, register the tip, and place it using the technology? And the answer is probably yes, you'd be better, but not necessarily. Because when you look at Luigi's numbers, when he placed the implant, not guided, freehand, but he had created the osteotomy site using dynamic navigation, his numbers were a little worse, but not too bad. 0.77 millimeters versus 0.62 millimeters. What did happen is the implants were placed a little deeper than when they were placed using dynamic navigation. Again, you're talking 0.2 millimeters. That's even difficult to measure. And the angle discrepancies were also not quite as favorable as when we followed the plan using navigation from start to finish. But again, depending on the circumstances, if you place the implant freehand, but you had created the osteotomy site using navigation, you really had very, very favorable numbers. I would say even better than traditional CT scanning, stereolithography, computer-guided outcomes, and certainly much better than freehand surgery. So again, these are some of the numbers, and these are what we can compare that to what's in the literature. When you compare static guides, you compare dynamic navigation from other systems like XNav and Mike Block, these numbers are even better. And a lot of that is due to Luigi's talents, but he's something that we can all aspire to get to, and we can definitely all get there. When you compare it to static guides, certainly it's as good, if not really, it's really better. So in the aesthetic zone for me, it's hands down, this is the way to go. Real-time verification and validation of positional accuracy, that's the trajectory of the profession, that's where we're headed. We'll need more studies to verify and validate, but they're on their way. And this is a really exciting time to be part of the Navident team. So I want to thank you again for sitting with me for 3 parts through this presentation. I've done my best to kind of show you what what I've accomplished in the last year and a half. This is my email, so if anybody would like to email me questions, if I can be of any help at any time, please let me know. But I want to reiterate that this is a work in progress, and that the team that you have at Navident will support you and definitely they're there to make you better. So lean on them when you have questions, when you need support. It's an email. Jason and Ido and Nima and Duran are really only an email away, as am I. So thank you, Jason, for having me, and great to be with you again, and thank you for the opportunity to share my work.
Excellent. Thank you very much, George. Appreciate it. I almost broke into a chorus of lean on me there to make sure everyone can lean on us when they're not strong. But what I really appreciate, I always appreciate your presentation, and I especially appreciated what you just showed, in that you're showing the collaboration between people in different parts of different parts of the country and different parts of the world. So just on this call alone, we have Toronto, Abu Dhabi, the UK, Bolivia, Australia, Italy, and Chicago, someone in your town. So every one of these people has experience with the system, but it's in that sharing of what we do back and forth with each other that it's going to get better and better and better. And obviously we thank Luigi for creating a lot of that information in the study and continuing to do cases on a daily basis, as you are as well. And it's nice to see Sylvia, who's a relatively new user, really taking to it, and she's very she's a periodontist. Her husband is an oral surgeon. They both use it, but Sylvia is very meticulous and takes a great deal of time and energy to perfect something, and she takes it on. And she's certainly doing that. She's going to be a great member of our family, as all these people are. So having said that, question and answer period. If people have any questions, they can certainly feel free to type them up. George, Ido, or potentially myself will answer. One thing, George, just while we're talking, some people love using the head tracker for maxillary cases. Sylvia, for instance, is one who would prefer to use the jaw tracker, same as for the mandibles, who prefers to use that in the maxilla. Do you see yourself, I know you haven't done that yet, do you see any advantage in that for you?
I absolutely do. As much as I love you guys, and I think you've made great strides, the head tracker, I feel, is a bit obtrusive. It's easy to hit. So I see myself probably in the future, when the number one, as long as you're aware of the head tracker and you're not, you're not insulting it, you're in good shape. But if the circumstances are maybe more applicable to using the jaw tracker, it's simple to attach. I would be more than and I will be using that. So I think it depends on the operator's preference. The one thing about the jaw tracker, the MaxiRef, the head tracker, Jason, is that for those of us that tend to kind of drape the patient from top to bottom, it does get in the way a little bit. So you kind of feel like you're doing maybe not so much of as sterile of a procedure. One of the other things that we need to also be mindful of, because there will be critics, is that when you use the implant as a drill tip and you're registering the implant, there is the question is there a potential now to develop a retrograde peri-implantitis?
Yep.
Okay. So we have to be a little mindful of that, and that's where I think Luigi's study was really very valuable, because he showed as long as you use the technology and the accuracy inherent within it, and you place the implant, even manually, you're going to get a very, very accurate result, if not more accurate than using stereolithography.
Yeah, that point, as you mentioned, 0.12, 0.13, it seemed to be the average difference when he guided the implant and he didn't. And I know a lot of you are taught in dental school that implant's sterile and it's not touching anything unless it comes out of the package, goes onto the tray, and then into the mouth. So we certainly don't advocate one or the other. It's just it's a clinician's preference. and whatever they deem necessary, whatever they feel comfortable doing, they do.
Sure. Yep.
Yeah, Sylvia, for instance, she won't
Yep.
guide the
I know.
implant. Some people guide everyone.
But that will be something that comes up, and you know, like anything, the devil is in the details, you know, and it's the scrutiny of what we do to get better. So,
regarding the head tracker, of course, as with all of this, we're in a beta phase. George alluded to the fact that we go with 3 points to trace, and then back for 2 points, 4 points to trace. Just for your information, the latest update, which you now have, we're back to 3. So you can do 3. And that's up to you. You can do 4, you can do 5, you can do 6, but you can do 3, because what we determined, we've done, Arish, our main developer, has been doing a lot of testing with the old stent and fiducial versus the new trace registration. And when we do 3 points in trace registration, our accuracy is 0.4. We're down to 0.4 millimeters. Of accuracy, which is basically the limit of the camera, the limit of the system. And then with the fiducial, consistently it was 0.52, 0.53. So we've drastically increased, and that's with doing 3 points on the tracers. So if you do 4, it goes up by, I believe, 0.3 or 0.4. So not super significant, especially if you're only placing 1 implant. So if you're placing 1 implant, you know, you pick 3 points very close to that implant area, trace those, and you're all set. If you're doing 7 implants and they're spread out around the entire arch, then we would probably encourage you to pick 4 or 5 points and do that. But the beauty of it is you can do 3, check your accuracy check. If you're not happy with it, you can do 4. And certainly if you're placing that many implants, you're probably willing to take the time to ensure that everything's going to be perfect for the patient.
yeah. Great.
Just while we're waiting for questions, just to show that George is actually going to have a course on September 15th. So you can sign up for that course online. That's going to be a live surgical course with he and his partner, Bradley DeGroot, that will be in his office in Chicago. You're going to see a live surgery. You're going to learn all the basics of trace in place and Navident in general. And that runs from 8 until 4 o'clock. So you can sign up for that on our website. You can also email myself, and all of us are just at clarenab.com, our names. So Jason at clarenab.com. You can email Beth at clarenab.com, or you can email Kamisha at clarenab.com. Any of us, and we'll make sure that you get signed up and you get a really great experience in Chicago. And if you do that and then you want to take another course right away and learn even more in a different state, in a different city, then the McGuire Institute, Mike McGuire, Todd Shire, and David Lipton will be holding a course in November. So you can see that up on the screen right now. That's from 8 a.m. to 4 p.m., and it's on November 9th in Houston. So both those people, Luigi is doing several courses. So those of you who are closer to Europe, you can certainly look at our Dynamic Navigation Society website and see the Luigi Silken courses all the time. And I see Dr. Sheikh on here. So if anyone's interested in a trip to the Middle East, he's doing courses in Abu Dhabi. So if you're happening to be in Abu Dhabi, or if you've got there are a lot of events in Dubai these days, make sure you go by and see Dr. Sheikh and also take a course. He's been very instrumental in doing courses for some of our Indian and Middle Eastern users as well. Okay, so I'm not hearing any questions. I don't know, do you guys have any other points you want to make in particular? All this, as I mentioned again, these 3 webinars, 2 of them right now are available on the main page of our website, on the first page when you go there for download. This one will be up next week with some great valuable information. Do you guys have anything else to add?
No, I just...
Well, the great thing about this, you know, we've got users on here right now from all over the world, and we know that several people have signed up, and several people are asking us when they can download these and when they can see them. So while we do have an audience here, hopefully these videos will be kept for posterity, and people will use them and look back at them and remember when they did their first trace in place. So Thanks very much, George. We appreciate it. Thanks very much, Ido. And thank you to all of you for logging in and listening and for being members. Thanks very much. We'll talk to you all soon.